a patient feels like you're blocking the line of egress. They feel like you are in the way. They feel like maybe panicky that they want to get out of this place. It was not a place they wanted to be in the first place, and they will bolt for the door. We often don't get hit when this happens, but people will knock us over. And this is actually one of the main areas of injury is from blocking the door. So I recommend, and I notice many of the rounding psychiatry teams do the same thing, starting near the door jamb where I'm there, but anyone can run by me if they need to. If I need to get around the doorway, I can do it and get out of the way. Hard to remember. It's hard to think that that's a threatening kind of position to be in. It's blocking a door, but it is. So what if they do run? I will admit that in my early days, I was one of the foolish people who would chase a patient down, because I thought at the beginning that, oh my gosh, this patient's suicidal. What's she going to do? She's going to run away. She's going to jump in front of traffic. Something bad is going to happen. I have to be the one who stops it. It's this patient's under my charge. Or that person was violent and they're on a 5150. They can't run away. I need to track them down. Believe me, I'm not the only one. Many bad things happen when you do this. One of the silliest positions I found myself in was chasing a patient out of Highland who was suicidal. And she ran out into the waiting room, and in front of a waiting room that's as packed as this room, even more packed, I caught her. What do you do when you catch someone? It's not tag, right? It's not like, you got me, kick the can, it's all over, I submit, we'll come back. No, I caught her and then I didn't know what to do. She turned around and rabbit punched me right in the face like a cartoon in front of a packed crowd, and there was nothing I can do. And the faces look like yours right now, just kind of bemused, because a patient in a gown and paper scrubs was rabbit punching the doctor, and there was nothing I could do. And other times it's the other way around. We're not trained to do flying tackles and bring people down to hard surfaces. You see some of, I've even seen our former, she's very prominent and nationally prominent head of the residency program run down and do a flying tackle and take a patient down in the emergency department. And what were we doing? It's people get hurt, then you have to do an IR, someone hurts their head, there's a strike, there's an injury. It's nothing good comes out of it. Call the professionals and let them run after the patient, and be ready to help for medical help and management. All right, so you've made first contact, you've gently woken the patient, you're respecting personal space, and it's now time to use verbal de-escalation and use your clinical and personal skills to help relieve symptoms and keep you and the patient safe. This is the emblem of the New York Police Department's hostage negotiation team. They are the first such team in the world, and they are the elite of the elite. The best of NYPD are trained and selected to be in this division. They talk people who are holding hostages on rooftops and guns. They talk people off of roofs, and their motto, which is on their badges, is "Talk to me." Even the best police departments, the best of the best, have verbal skills, and we should learn how to do it. Luckily, in this department, you probably have some of the world experts on verbal de-escalation as well. What's the first what's the first rule of verbal de-escalation? It's not what you say, it's how you say it. The first rules of verbal de-escalation are all the nonverbal stuff. So before any of us understood language, we understood whether our mother's face was happy or sad. We understood the tone of the voice coming out. There's a lot of things we understand before we absorb any words. And I guarantee that there's a lot of, well, we'll talk about it. Let's just start with body language. How do you put your bodies to not be threatening and to de-escalate someone? What we want to do when we're afraid because a patient seems dangerous to us, or they're saying mean, terrible things that are making us angry, is we tend to go into one of two positions. One is kind of a defensive, aggressive kind of position, a kind of a John Wayne macho kind of thing, or we can do the opposite. We can look very, very afraid and kind of express through our body language that we're afraid and that we could be victimized. And so it takes some practice actually to purify our body position of either one of those conditions. So a place to begin is to unclench your hands and unravel your arms and get your hands down to the side like this. Don't stand straight ahead. Stand a little bit to the side. This way, you can actually fend off blows. Any striking blows, they can come off to the side, and it's a slightly more athletic position as well. By the same token, knees slightly bent, ready to move, but soft. Head and eyes are not drilling into people, not weird eye contact that's aggressive, not furtive eye contact that seems like you could be victimized, but just kind of a natural eye contact. Head maybe a little bit to the side. And when you're doing it right, you look a little bit like the statue in the church where I grew up of the Virgin Mary. It's kind of in a non-threatening, very soft and authoritative position that is a good one to start on. The Highland residents, they come and tell me sometimes, like, Jim, I tried it. I tried the pose and it worked. You know, as I just tore myself ahead of time and I felt better. It worked. The other thing is tone of voice. So admit it. So every one of us has had an experience where we've talked to someone, we've spoken with a consultant whose tone, even though everything they said, if it were a recorded conversation, would be blameless, but the tone was so condescending or so mean-spirited or fill in the blank that we came out of the conversation feeling angry and mad and upset. Very hard when you're dealing with someone who seems threatening to you, who seems to be breaking all the social rules, not to develop a tone that's scolding, kind of bossy, condescending. I think condescending comes out more as much as anything, because there's a pretty big power differential when you're talking to someone who's in bad straits needing to be de-escalated. And so making sure that the tone doesn't come across that way. So what tone do you aim for? I've decided, and I've actually read other things that would support this, that the tone to aim for is a normal tone. It's like you would talk to your friend. It's like you said, if my friend were in this position, how would I be speaking with them? And that's what I aim for. And I think that that's a good rule. Everyone, you can experiment with your tone like you can experiment with the tone on an instrument. Bring it up, bring it down, see what engages the patient, but be conscious of it. Okay, so now you actually have to say something. You've got your body position in a natural, non-threatening, but somewhat authoritative position. You have your tone mastered, so it sounds normal and inviting, and now you got to say something. Well, the first part of saying anything is just listening. So that's why it's talk to me. What is the patient saying? What can the patient tell you about his or her position that helps you? What do they want? What are they afraid of? So at the beginning, talk to me. Tell me, what can I do for you, sir? Tell me what's going on. And then listen attentively and see what you can find to help with. Easiest way to do that is, the old-fashioned reflecting back to someone. So what I'm hearing is you're mad because you were brought in against your will, or you're mad because you think your phone is broken. Any number of things. One of my favorite examples of this is when I was in the East Bay. Police brought in someone who was found naked, covered in blood at his mother's doorstep. Came in a horse wrap, like a blanket from EMS, and I could tell that the expectation was this would end with some kind of takedown and with a Haldol being administered or some other anxiolytic. And but I was studying these things and decided I'm going to try to talk, and was able to ask, sir, so what's happened? He said, well, I I wanted back into my house. Well, why are you naked? Well, I wanted to show my mom that I'm not ashamed. It's like, and why are you covered in blood? Well, I killed a chicken because I was hungry. So I hear what you're saying. So you were found, you were naked because you want to show that you're not ashamed. And it sounds like you killed a chicken because you're hungry. Would you like something to eat? Like, yes. Are you cold? It looks like you're probably cold right now. Yeah, and is there some medicine that would help when you're in this position? Yes, I'm off my fill in the blank. I'm off my Zyprexa. Even someone who seems violent, that everyone's in a way getting ready for a takedown, for a violent interaction, even someone who's really in the depths of some pretty decompensated psychosis can talk to you, you can understand needs and wants, and you can reflect them back and provide some pretty low-hanging fruit to make people feel better. And it's hard to remember that sometimes when someone seems really potentially violent and decompensated and maybe threatening. Showing empathy, offering help, and is always advised. One thing about is a tip is to have only one person talk at the beginning, and I don't care who it is. It doesn't have to be you. If someone else has a great relationship with the patient, they're engaged, and they've had a good relationship with the nurse, bedside nurse, for example, and there's an escalation, and we all come running to find out what's going on, offer support. A tendency can be to everyone start talking at the patient. Then you hear it's very disorganizing and too loud and confusing, all these voices telling you what to do. So one rule, same as in the code room, is only one person talks. You're running the code, you're the de-escalator. We stand back. If this person's having problems, they can tag out. If it's not going well, then the next person can come on and begin. But I think it's really much less stimulating and much calmer to have just one person talking. In all of medicine, we have a tendency to use too many words, basically, whether it's we're giving a cancer diagnosis or some bad news, or we're talking to someone who's really agitated, we tend to talk too much. So keeping the language very, very simple is always a tip for us. Sometimes you have to repeat yourself, and it seems like you're saying the same thing over and over, but it's necessary. Just repeat yourself. You're safe here. You're safe here. What can I do for you? You're safe here. You're safe here. Sometimes I found it's almost like there's something in, I don't know if you know what capture pacing is. It's when a heart rate goes too fast and the pacemaker will go up to the rate of the heart, and then it will slowly bring it down to the desired rate. I find that in de-escalation, it's almost like that sometimes, because if a person's got a high energy level and they're really speaking fast, you kind of don't hit the right tone when you come in. It's like, hey man, like, why are you so upset? It's too calm. It's like it's too slow. It's kind of like you want to kill your friend when you've had a terrible day, and like, hey man, like, why are you so upset? I can't, why don't you just chill out? It's like, are you kidding me? Like, I was talking to you for 5 hours, and then I had, a terrible thing happen at work, and you want someone to say like, no way, like that's terrible. Like, I can see why you're mad. It's like, we should go out to dinner. Why don't we just forget what we're doing tonight and just bring it down like this and slower and slower. So it has to be this kind of repetitive beginning level where it's kind of high energy and kind of fast, and then you're at the same level of the patient, you can kind of come down and bring people down. Very tempting to argue, because sometimes people are saying things that make no sense and are downright offensive. Really, really hard to remember not to argue. Just have to say to yourself, why am I arguing? So find things to agree about. Agree when you can agree, disagree when you can disagree, and just leave it there. A very nice tip I heard one time was from a psychiatrist from Pennsylvania who said, something I've learned, though, is that don't agree with delusional or psychotic opinions. If a person is telling you the Martians are coming and they've got a message for us all, and don't you see them? Don't say, yeah, I see them, or people know that you're full of it then. You can say, you find a way to agree. You know, it's like, I agree that you might see Martians, or I can understand how that would be upsetting. But in general, be honest. You don't have to agree with anything that's really, frankly, not true, and just find a way around it. If you are in the position of offering medications that would be indicated in therapeutic, based on this idea that earlier is better, absolutely. If this is headed towards medication, do it early. If you're not a prescriber, do what the non-prescribers in our department do, which is say, hey, I'm worried about this person. They seem really psychotic right now, and I think they're escalating. They come and get me. If you're in that position, go get someone. People don't want to see someone when they're florid. They don't want to see what it looks like up here to make a diagnosis. This is when people get hurt. We don't need to wait always for the antibiotic specificities to come back before we treat overwhelming sepsis. You can sometimes just say we have enough to go on. We need therapy and we need safety. For succor, what's more friendly than offering someone food? It's very ancient. It's an ancient, hardwired way that we are, that when you break bread with someone, you're kind of offering an olive branch and a peaceful way to be with them, and it's going to make them feel better. You don't have to understand much. You can be even pretty disorganized and pretty agitated to know that this is a friendly thing. And furthermore, I would remind you that many of the patients we're seeing have been on a meth binge for several days, and have not eaten. And people get hangry. I really, really do. It's amazing. It's good medicine. Food really makes a difference. When people haven't eaten for a long time, getting some food on board really helps all the downstream interactions, I feel. The other thing is, it's a great thing to talk about. It's like, sometimes I'll talk to someone and they'll be telling me all the things that happen. And it's a long, long tail. And I can just say, oh my gosh, you must be so hungry. When was the last time you ate? Yeah, it's been like 3 days. Yeah, let's get you something to eat. Hold that thought. I'm going to go get some food and get some food going. And it's amazing. I actually want to do study. Come and find me at any time if you want to do the study with me, especially with the new law, SB 1152. Does anyone know that law? So homeless patients have to be offered food in the hospitals, and by law now. And I think that we could do a study where we said, offer food up front at the beginning versus wait for patients to ask for food and do it in the normal way. And I bet you would find that if you were offered food up front at the beginning and could get out of your hangry food hole at the beginning, that your disposition time would be shorter, and that people would, there'd be less violence. My own theory, you want to do that study with me, I think would be great. This is another really hard one. So don't escalate people. Do no harm. And this is hard because, and especially for, I would say, the people who have to spend the most time with patients, especially bedside nurses, who have kind of heard a lot of mean things all shift long. There's been some frankly offensive things get said to people. We're all human. It's hard not to take offense sometimes, and it's hard not to want to get some revenge sometimes. And so there's a tendency, everyone has it, to kind of get back, get your little dig in, say that little thing as payback, and then you know what? You walk away, your shift's over, the patient stews, gets mad, and the next person that walks in the room gets hit or punched or kicked, all because they were escalated by a previous provider. It's human nature. It's something that a person's tempted to do, but even if it's not you're the one that gets hurt, you're really doing a disservice for your colleagues who follow behind you. Probably this group as a group is probably less inclined to do that than probably any other place in the hospital, but it is hard to remember sometimes. Here's the one I have hard times with, and I would love tips from the experts later on, but it's hard to set clear limits. People, and you got to be careful with what limits you set, because if you end up fighting over something that was silly and you're bringing in the whole takedown crew because the patient did that and you told them they couldn't get out of the room and they're doing this kind of thing, that's just not something you want to go to war over. You don't want the collateral at all for that kind of thing. So it has to be real limits that make sense for you in the department, and you have to be able to back them up. And you have to be able to coach the patient into succeeding, help the patient win that limit. It's like, I see it's hard for you to stay in this room. I really can't have you outside because there's all these patients here who are sick, and some of them are children, and we have to respect other people's privacy. So I really need you in your room. What do you need in your room that could make this better for you? So I really just help the patient win. But you have to be able to use a show of force and be able to back your limits up when it's necessary. One of the easiest ways that can prevent violence actually is a show of force. Do you guys have a way to do a show of force when it's necessary? Everyone should come. Everyone should come to the shows of force. Even the social workers who can't keep a straight face during the photograph should come. And but it's just also human nature that people will back down when they're not going to win. When it's noble to back down. There was too many of them. I couldn't take them all. People don't want to fight all these people in general. So this prevents a lot of escalation. And then if there is kind of an acting out, then there's lots of people to help. Everyone gone over the active shooter instructions? Everyone pretty familiar with them? It just seems every week there's another terrible tragedy, and it always seems like it's just a matter of time before something happens here. Some of this is counterintuitive. It seems like you should run and save the day and help out, but basically the instructions are to do the absolute opposite. Run away when you hear guns, save yourself. You're rushing a person with an AK-47, doesn't save anyone. Hide if you can't run away, and only as a last resort, you fight. And then when you fight, you fight serious, like whatever weapons you can find, oxygen tanks, scissors, anything, you fight with all your might. If you are unfortunate enough to be involved in a violent event or traumatic event, find help. Be active about it. If you know friends or colleagues that have been in something, reach out to them actively and get them help. There's many resources in our hospital. There's the Caring for the Caregiver organization, and then we have counseling available. People quit their jobs, they quit their careers when they've been involved in these things. It's real. These are lasting scars, and people should get help. So with that, I think we'll open it up to the crew and see what kind of comments. I'd love to hear advice, your thoughts.
When I have a patient who's really acting out and being very offensive, the first thing I try to do is align myself with the patient. So instead of saying in my mind what's wrong with this person, I shift it and I say, what happened to this person to cause them to behave in this manner? If I don't say a word to the patient, but I say that to myself, the patient immediately senses that I'm sympathetic towards them. Doesn't mean that I continue to endorse their inappropriate behavior, but at least they know that I'm there to help.
And you can feel the difference when you're able to do that, you think.
Immediately, just kind of yes.
That's great.
Do you give any specific recommendations for female residents or med students that are different than male?
It's a really good question because it comes up in our residency a lot. When do female residents want a show of support and that people are watching out for them versus when do they want to be left on their own devices? I'm dealing with this. I don't want support right now. I listen with fascination every time that's brought up in our residency, and I don't have a clear answer after all of that, except I would say personal space is kind of all these recommendations up to this point, I have to say, are pretty gender neutral. Like if you can stay away and give space, that's really important. And maybe something that tends to be a little less gender neutral is, I would say, in my experience, men have more of a tendency to do the cross-armed kind of, we're going to fight. And sometimes I just have noticed that women are less prone to do that. Doesn't mean they won't, but that's a difference I've noticed.
Yeah, I can comment on it also. So it's a complicated question. There have been studies where a lot of inpatient units where at night people want men to be, male nurses, to be on the unit because the female nurses are frightened. There could be an event and they feel more vulnerable. But there have been counter studies that when you have a unit and it's only women who are staffing it, that there's less violence because people are less threatened. We've also done studies in terms of who's more likely to be assaulted. And when a patient is acutely psychotic, the difference is they don't care who you are, whether you're a man or a woman. I mean, maybe when they're not psychotic, they may be less likely to assault a woman. But when they're psychotic, whoever is in authority and whoever is setting limits and not doing the things that Dr. Hardy has recommended, the patients don't even notice it. I mean, I can remember being on the inpatient unit. I was 9 months pregnant. It wasn't subtle. And a patient just starts screaming at me because I was, talking about the hole. And then suddenly the patient comes down and says, "Oh my God, I didn't realize you were pregnant." I'm so sorry. I hope I didn't hurt the baby. And I said, "Oh no, you didn't hurt the baby." But it was just in the moment of psychosis, they didn't even notice who I was, what I looked like.
I'll just add one thing is that same Penn psychiatrist that had recommended to not agree with frankly false statements or delusional statements. She had found that it was useful for her to be really frank with patients and say, "The way you're talking is scaring me. Like that's frightening. Why would you? I can't believe you would want to hurt me or hurt this person." And she found that was hugely effective, and many patients responded like, "Oh my God, I feel so bad. I would never want to hurt you. You're pregnant. I can't believe you're pregnant."
Right.
It's like, and that happens actually pretty frequently. It's like when you call someone else, like, "I can't believe you would hurt that person." They say something aggressive, it's like, and they're filled with remorse. It's funny.
What's the patient's death?
Well, it's a great question too. I have a story. How salty of a story are you willing to hear?
Pretty salty.
All right, okay, good. So at Parnassus, during the Hardly Strictly Bluegrass Festival, I brought in a patient who was deaf and did not speak American Sign Language or any sign language. He had been found at the park during the festival masturbating and was brought in, and once again, he was kind of upset and was trying to get out of the room, and he was kind of making verbal utterances that no one could understand, and seemed like he could be aggressive. And there was once again a huge crowd gathering around, and it looked like it was going to be a fairly violent takedown. And no one could get his story. All we knew was that he might have been intoxicated and he had been masturbating. So they said, "Well, Jim, give it a try." It's like, okay. So and so as much as I understood without him talking, I tried to reflect back to the situation, kind of like we said. And I was like, it's like, "Are you drinking?" He's like, "We're masturbating." It's like, "Yes, yes." I said, "And you just kind of want to sleep and eat?" He goes, "Yes." And then he gave me a hug, and then gave me a fist bump where he kissed his fist first and gave me a fist bump. And to this day, in the department, people will come and give me a kiss like that. It's like I maybe had wished he'd washed his hands first, but But the same things apply, like some effort to understand whether you can get a sign language, can you write, can you make some desperate attempt to communicate, to see it from the patient's side, and to reflect that back as best you can, even if it's down to like a sandwich, something. Some people are deaf, they also just just talk. So you're kind of in the same situation. So. Does anyone else have pearls for that? Any advice? I'm happy to take advice as well. Dominic?
So, particularly for inpatient EDs, patients can be in care for a long period of time. It's true in outpatient also. One of the key things throughout healthcare is just good handoff communication teams, providers, shows. So with patients that there's been an escalation, de-escalation, pitfalls or things that you recommend to avoid or to
We tried to formalize our handoff, especially after there was a bad case where someone had escaped the rig and committed suicide. And looking back through our sign-outs, what should be continued on each session, each handoff to make things safer. I think it's always good for us to know basically what the status of the hold is. I like to know whether there had been any active escalation or violence in the preceding shifts, because it's amazing how often that's not handed down. It's like, hey, 3 shifts ago, this person was hitting people, and people have already forgotten that. That's already fallen off the sign-outs. And how can that be? It's a terrible game of telephone. So that has to be communicated. If there was ever a violent episode on this day, that should be communicated forward. I like to know where are we on the medicine so far, like what has been given so far and what are recommendations if there's another escalation. And then any other situational thing like, hey, the patient, really, has made the female staff feel afraid and responds well to male staff, that should be communicated. We might change the sign-outs and the assignments based on that. Some other subtle things like that, don't let the mother there, she just stirs him up, that kind of thing.
Have these banners of people who have hurt people or acted out or whatever on patient records. Can you talk about those? What's your experience? Are they? I don't know if they're helpful, and I worry about labeling. Okay.
Yeah.
Here's this terrible person. Here I am. Everyone, watch out.
Yeah.
But at the same time, watch out.
Right. We debate this all the time, and then also is there just banner fatigue and alert fatigue a little bit. Sometimes for us they're the pumpkin color. Is that what you get in Epic? The pumpkin color. That's the previously violent color. Sometimes we get a whole block in the back area of the in the ED, and we call it the pumpkin patch because it's just a solid row of pumpkin colored patients. Some of them are pretty silly. You're right. Like you go back and there was like an incident long time ago where someone got upset about their discharge medicines, for their oncology appointment or something like that. And she's like, that's not very helpful. But I think for the moment, I don't mind them. I don't mind taking a little kind of chart biopsy just to scan through for what kind of violence are we talking about. Was it concealed weapons before? Was it really like really violent things? I think that's worth knowing for the moment. Yes, we're all at risk of labeling, but that's the medical chart for you a little bit. So we can always anchor. Feel free at any time to email me, come up to me, send me your tips, send me your stories, any thoughts, any insights, any way you would change this presentation. Let me know. I would love to hear your thoughts, and I'm definitely open. This is a work in progress. I've changed it over the years. Stay safe, everyone.